Tonight, we'll discuss something the presidential candidates in this long election year have avoided like the proverbial elephant in the living room: real health care reform. Both Senators McCain and Obama have plans they put forth and argued over in mind-numbing detail, but to use a recent heated campaign metaphor of lipstick on a pig, this pig's covered in Band-Aids went to the market, but the market's crashing. While we pay more per capita than any other country in the world for health care that nobody seems particularly pleased with, that leaves between 40 and 50 million of our citizens without coverage, that has costs multiplying without any restraint, and is the principal cause of bankruptcy, yet nobody seems to want to talk about how the rest of the developed world takes care of its citizens' health with universal coverage at a fraction of the cost. Tonight we'll remedy this willful denial that apparently the media and the politicians are in bed with, and have a discussion about what works everywhere else, but that we, here in the land of the free and the home of the brave, apparently can't even debate. Tonight, the co-founder of Physicians for a National Health Program, who advocates a single-payer system of universal health care, joins us. You probably could not have come up with a worse idea than putting insurance companies in charge of health. Instead of charities and non-profits who used to run hospitals, we have put Dracula in charge of the blood bank. With insurance companies, the parasites, and our vulnerable citizens, the unwilling hosts. To insurance companies, healthy people represent profit, and sick people are a liability and an expense. In effect, they are the mafia, an unnecessary layer that collects for doing nothing while impeding the relationship between the caregiver and the patient. Whatever their overhead is, it justifies their existence and allows them to mark up their own profits. And it has to come from somewhere, and it does, out of patient care and at your expense. A front-page story in today's LA Times tells it all, with insurance companies withholding payments and forcing the closure of hospitals. How do they get away with it? Well, they do, and just like the mafia does, they buy politicians. An insurance company or a pharmaceutical company can buy a politician for a few thousand and make millions. A senator can slip in an extension on a patent on a drug into a bill that could earn an extra billion for the drug company before the public gets the benefit of a lower-cost generic drug. And the budget-busting so-called Medicare prescription drug benefit bill that was muscled through by Republican congressmen who later became lobbyists, or in Bob Ney's case went to jail, specifically prevented the government from bulk buying drugs for Medicare patients to save taxpayer money. So before I get so enraged that I might need to be attended to by tonight's speaker, we'll hear from Dr. Steffie Woolhandler for about 15-20 minutes, then we'll have a discussion, and then open up a dialogue for Q&A with you, the audience. Dr. Steffie Woolhandler grew up in Shreveport, Louisiana. She practices primary care internal medicine at the Cambridge Hospital and teaches at Harvard, where she is an associate professor of medicine and co-director of the General Internal Medicine Fellowship Program. In 1986, she co-founded Physicians for a National Health Program, which advocates a single-payer system of national health insurance for the United States. She has authored more than 50 research articles in major peer-reviewed journals on healthcare access and financing. She lives with her family in Cambridge, Massachusetts. Ladies and gentlemen, Dr. Steffie Woolhandler.
Well, thanks for introducing me. That introduction was so colorful, it's a bit of a hard act to follow, but I'll get a copy of your script and add it to my next talk. And I do want to apologize. I prepared a much longer talk than I have time for. I didn't realize it was so short, but that's fine. I'm just going to skip through a bunch of slides, so don't try to read them real fast. We'll just be skipping through. I'll be a little constrained. I've been compared unfavorably toward Al Gore. There's so many slides and charts. So It's a problem I have. I'm a physician. I'm very detail-oriented, so I always present a lot of detail. I also have a degree in economics, and when my friends really want to tease me, they tell me that an economist is someone who didn't have the personality to become an accountant. Okay. So there's way too many charts and slides and numbers here, and I will skip over them, but I do want to offer them to people. I'm going to put them up on a website. You can see the whole presentation, even the large parts of it that I'm going to skip tonight. And I'm actually quite happy with the shorter speech format because I feel like we'll get to hear your ideas, and I'll get to hear a lot more of Ian's metaphors, which will be great for me. But anyway, the central metaphor I want to talk about is lifeboats for everyone, health reform and economic maelstrom. And no one in this room can tell us whether we're in a long, deep recession or if we're heading into a depression. No one knows that, and certainly the people we thought were the smartest people in the world were wrong on this. But everybody knows that we're facing at least a recession, and every major recession in the past, the majority of American families have faced a loss in income. So we all know what's headed our way, hopefully in the short term, but perhaps longer. So the question is really, how are we going to survive this recession, and what is the role of healthcare in terms of allowing people to do so? But I want to talk a little bit more about the recession, and this is from John Maynard Keynes. Speculators may do more harm as bubbles on a steady stream of enterprise, but the position is serious when enterprise becomes a bubble in a whirlpool of speculation. When the capital development of a country becomes a byproduct of the activities of a casino, the job is likely to be ill done. And of course, Keynes is talking very presciently about the economic situation, but to some extent, this is actually a description of the healthcare system as well, in that within the healthcare system, we're currently spending about 31% of the total healthcare budget on the paperwork and administrative side, the financial manipulations that sit on top of the productive enterprise of healthcare. And that's about double the administrative costs in Canada. And it's, of course, represented in this slide where I've graphed the growth in the number of physicians over the last few decades in yellow at the bottom and the growth of health administration in the top in blue. Now, I told you I was going to use a central metaphor of the lifeboat, and this, unfortunately, is a rather blurry picture of the Titanic, all right? And we all know what happened to the Titanic. Like the derivative market, people said it could never be sunken. But you probably don't know something about the Titanic. It's one of these facts lost in history. The chances of survival, if you were on the Titanic, were very closely related to your social class, so that large numbers of people survived on the upper decks, the rich people. But among the poor people in steerage, most of them went down with the ship. Okay, and a lot of people don't know that. So the question is, as this bubble bursts, as the economy goes down, as at least some of the ships go sinking, will there be lifeboats for everyone, or will it be a situation like the Titanic where they had half the lifeboats they needed and affluent people were saved and other people went down? So, of course, when we talk about health insurance, we tend to focus on the 46 million uninsured. But we also need to talk about the issue of costs, as Ian kind of pointed out, and healthcare costs per capita as a share of GDP are graphed in this slide, and the United States is really towering above Canada, which happens to have national health insurance. And literally, the analogy of the lifeboat is very apt, because if you don't have health insurance, you may in fact die, as do about 18,000 adults annually in the United States. And the U.S. now leads the world in preventable deaths. That's the yellow bars of the most recent year. We have more preventable deaths in the United States than other developed nations. And as Ian pointed out, we also have health care and medical bills contributing to about half of all personal bankruptcies. And I just want to call your attention to the last line of this slide. About 76% of people in personal bankruptcy because of medical illness or medical bills have health insurance at the onset of the illness that bankrupts them. Now, how can that happen? Well, it turns out many people who have health insurance are underinsured, and in this slide I'm just representing the share of people who spend more than 10% of their income on health care. By 2008, there were about 60 million Americans spending more than 10% of their income on health care. The majority of them, the blue part of the bar, did have health insurance. So underinsurance, people with only partial coverage, at risk for bankruptcy despite having health insurance. Now, there's a tremendous amount of clinical waste within the healthcare system, unnecessary and even harmful care. I'm going to skip the detail on this, but it's estimated that probably about 20 to 30% of all of the healthcare delivered in this country is completely unnecessary and perhaps even harmful. And if you go to, I will put the slides up, the waste can be quantified in terms of total health spending, where different areas in red spend much more than the light-colored areas in white, and in fact the areas that spend the least in the United States, such as Minnesota, have average higher quality than the areas in red that are the high-spending areas. So we know from that there's a lot of unnecessary spending, there's unnecessary procedures, and again, for reasons of time, I'm not going to go through this slide, and tremendous overuse of CT, MRI, and nuclear imaging, which unnecessarily exposes tens of millions of Americans every year to high doses of radiation, often equivalent to that experienced by Hiroshima survivors. Okay, if you have two CT studies a year in this country, or two CT studies, you may be exposed to the level of radiation at Hiroshima. Okay, people are not aware of that. Okay, ascendancy of financial firms in healthcare, very closely tied into the development of managed care, which was shown in a randomized controlled trial funded by the federal government, managed care associated with a higher risk of dying, okay, about a 21% higher risk of dying among people with any sort of chronic illness. Now, I tend to be very simplistic when I think about quality of care, and I think the very simplistic explanation of why quality of care and death rates are higher in the HMO setting is because of the very high overhead, that is the money that is sort of siphoned off the top of your premium dollar for the overhead and profit of the HMOs. These are the most recent figures I could find, but some of the market leaders, such as Aetna, take 23% of total premium as their overhead, meaning that for every dollar that goes to Aetna, only 77 cents ever goes to pay a doctor, a hospital, a drug company, a nurse. The rest stays right there at the HMO. So sort of the simplistic explanation about, why is the quality lower? Well, they just took too much off the top for their overhead. Some people do extremely well in the HMO setting. Multi-million-dollar CEO payments are really what's expected by these HMO executives. HMOs have become increasingly involved in the Medicare program and again offer another threat to Americans' retirement security. If you're like me, if you think about your retirement, you're counting on your health care being highly subsidized by the Medicare program. But HMOs have increasingly been able to talk Congress into allowing them into Medicare, and they're undermining that program. It turns out the HMOs and insurance industry have lobbied to be overpaid by Medicare so that Medicare pays about a 13% more every time a patient leaves traditional Medicare to enroll in an HMO. So a 13% overpayment to the HMO, leading to a big growth in enrollment. Again, these Medicare HMOs have spending almost essentially all of that overpayment goes on their overhead and profit, as represented on the left. Medicare Advantage programs is the name for the HMOs. And without reading the slide, I just want to point out that the GAO, the Government Accountability Office, previously the General Accounting Office of Congress, said that the HMOs endanger Medicare because of a $7 billion overpayment. They're depleting the Medicare trust fund that all of us are relying on in the future for Medicare, and they're causing Medicare beneficiaries to have to pay higher premiums. So the premium increases are directly tied to this overpayment of Medicare HMOs, again, endangering and undermining the entire Medicare program. Now, there's other investor-owned firms who are looking at health and seeing, well, here's an opportunity to make money, and they do undermine health security by raising costs and reducing quality. Very busy slide, but this so-called meta-analysis of the world's literature on the cost of for-profit hospitals, and the conclusion was that for-profit hospitals do cost about 19% more, and most of that picked up by the taxpayers, actually, through the Medicare program. For-profit hospitals offer the worst quality of care represented in The light blue colors are for-profit hospitals, lower quality for these series of medical conditions than nonprofit hospitals or VA hospitals, and that's myocardial infarction, heart failure, and pneumonia. And for all types of care, studies are finding lower quality in the for-profit setting, highest quality, sort of surprisingly, in the VA. Drug company profits, I'm not going to get around to talking about them tonight, other than to say that the drug companies are making profits 3 to 5 times the average for Fortune 500 companies. Okay. Now, people in other nations, all of whom have some form of national health insurance, spend less and are healthier. These people have the lifeboat. Okay. So they're facing economic problems as well. They don't know whether they've got a deep recession or they've got a depression on their hands, but they at least know that their health care is going to be covered. And that's something that they have and we don't. It turns out that they spend substantially less than we do on care. This is per capita health spending in other nations in blue on the top, and in the United States in yellow and orange on the bottom. So the United States is spending much, much more than other nations. The yellow part is actually the public tax-funded expenditure, and the orange is private expenditure. It turns out that public expenditure in the United States on health care already exceeds total expenditure, both public and private, in every other developed nation with the exception of Switzerland. Okay. Now, what do we get for the extra spending in the United States? We don't get longer life expectancy, and in this series of slides, I present the United States in yellow and everyone else in green. Our life expectancy is about 2 years shorter than that in many other nations. Our infant mortality towers above that in other nations. We spend fewer days in the hospital. We go home quicker and sicker than people in other nations. Even for medical journal articles, I teach at medical school. I care a great deal about this, but when you look at it on a per capita basis, our scientific output is not particularly good. Difficulties getting needed care. Again, 28% of the American people report difficulties getting needed care, much higher percentage than in other nations. And of course, we do tower above other nations in terms of insurance overhead. We're spending a whole lot more than other countries on the overhead costs of these Draculas in charge of the blood bank, to quote Ian. Okay, now national health insurance. I do work with a group called Physicians for a National Health Program, and a lot of people were kind of surprised when they heard about that, and one editorial writer made this little joke, Physicians for a National Health Program, that's a little like furriers for animal rights. But in any event, physicians, our group does call for an increased government role in the financing of health care. And we tend to look a lot at Canada, that has a national health program with the following 4 characteristics. It's universal, it's portable from province to province, there's coverage for all medically necessary services, if it's all medically necessary services, and a publicly administered nonprofit program. Okay. Public administration is important both to have an equal program, but also to generate that administrative efficiency that allows you to pay for the health care for everyone without any increase in total spending. And when we look at the difference in health spending between the U.S. and Canada, and you'll remember I showed you it's quite substantial, but if you graph the difference in spending as a giant pie, it turns out that nearly half of the spending difference between the two countries is accounted for by the difference in bureaucracy and overhead. Now, I want to talk about Massachusetts Chapter 58. That's our new Massachusetts Health Reform Bill. And the reason that's so important is because it is something of a model for what Obama has been proposing. It certainly was a model for what Hillary was proposing. The new Massachusetts law has some new coverage in it. If you earn less than 150% of poverty, it's free. You get like Medicaid, it's free. 150 to 300% of poverty, you get a partial premium subsidy, but you still have to kick in some of your own money. But above 300% of poverty, the so-called individual mandates, you're on your own. You're mandated, you have to go buy your own health insurance, and there's no subsidy. And people are going for these very high deductible health plans. For someone my age, it's a $390 per month is the cheapest plan, and it comes with a $2,000 deductible, meaning that if you got this plan after having paid $4,100 in premium, if you got sick, you still would have to take another $2,000 out of your pocket to get health care. So they're very, very bad plans, and you'll see in a minute that there's not been much uptake. To try to force people to buy the plans, we've got some new crimes and punishments in the state of Massachusetts. And you know, if you're an employer and you don't partially subsidize the health care plan for your workers, you have to pay a fine of up to $295. But if you're an uninsured person earning $31,000 a year in the state, the fine this year is going to be just under $1,000. And the bill, in fact, authorizes fines of up to $2,000 if you don't buy the insurance. Of course, then you're still uninsured. So it's actually quite punitive mechanism. Now, Obama has said he's only going to have a mandate, an individual mandate, that you have to buy health insurance for your children. Okay, but not surprisingly, if you understand the way this program works, the coverage has not become universal. Currently, we've covered about half of the uninsured in the state. We had about 10% uninsured. We're down to about 5%. And if you look at who's been covered, and those are the people in blue, by these three income groups, the poor people who got free coverage, most of them, you know, signed up. The low-income people who had just a partial subsidy, less than a quarter of them signed up. And of the buy-your-own folks, the folks who got the individual mandate without the subsidies, virtually none of them have signed up, only about 7%. So we still have substantial numbers of uninsured in the state of Massachusetts under what were, until this September, were optimal conditions, a very wealthy state with a very good economy. Still, we only got about half of them covered. Now, the mandate model for reform that is being used in Massachusetts that Obama is talking about was actually designed initially by then President Richard Nixon. And a mandate model, the government uses its coercive power to make people go out and give their money to private health insurance. That's what a mandate is. And it always comes with an expanded Medicaid-like program like we see in Massachusetts. It's free for the poor, subsidized for low-income people, and there's perhaps a buy-in for others, which Obama's been speaking about. There's an employer mandate with or without some individual mandate features, and there's always managed care management as part of it. So that's the mandate model, and that's actually what the Democrats have been talking about this election season. Now, the problem with it is the mandate model has no cost controls, so the expansion of coverage is completely unaffordable. And the Massachusetts reform, which is, you know, as I said, optimal conditions in terms of economy, cost about $1.1 billion and still only got half of our people covered. So at this point, the new coverage is becoming unaffordable, as clearly it would be at a national level. There's other problems with it, the kinds of things people talk about in terms of saving money that Obama talks about, like computers, care management, prevention. They may be good ideas. They've never been shown to control costs. Mandate models, because all the insurance goes through private insurers with their high overhead and profits, adds to administrative complexity and costs. It's got impeccable political logic. You know, don't step on the toes of the powerful insurance companies. That's impeccable political logic, but it's economic nonsense. You know, in this economy, we can't say we're going to cover 46 million people by just pouring more money into the system. Okay, it's economic nonsense. And you don't have to just project forward. We can look at a history of it, because actually mandate proposals were enacted in three previous times in the states. They were enacted in 1988 in Massachusetts by then Governor Dukakis, claimed it was universal health care. The New York Times claimed it was universal health care. I won't read you the quotes. But when we look at the share of uninsured in the state of Massachusetts with the passage of the Dukakis bill, you see absolutely no downward trend in the number of uninsured. Same thing happened last time as this time. The mandate model was just too expensive. It was never really implemented. Oregon, 1992, again, that's their governor bragging about universal health care in the Washington Post, saying, yeah, universal health care. But again, the share of uninsured in the states did not budge after passage of the Oregon Health Plan. In Washington in 1993, you're getting the idea of this story that claimed universal health care and no success at reducing the number of uninsured. We know this model will not work. It's been tried, and it failed. Okay, so there's no point wishing it could work. There's no point using a lot of wonderful rhetoric like Obama's doing to say this is going to work. It's not going to work. Now, I've picked on Obama. I want to talk a little bit about McCain. And McCain's agenda is really about continuing the Bush health agenda. So everything that Bush has done in terms of accelerated privatization of Medicare, getting people into these skimpier, high deductible plans, and he has a tax credit proposal with no plan, and I've got or probably no intention of ever financing it. But I do want to give you this quote because it's absolutely perfect. It came out in September of this year. It's unbelievable that anyone would say this, but McCain wrote, "Opening up the health insurance market to more vigorous nationwide competition, as we've done over the last decade in banking, would provide more choices of innovative products, less burdened by the worst excesses of state-based regulation." You know, and it is in fact what the Bush administration has been pushing. It is in fact McCain's health proposal is further deregulation, accelerated sort of privatization of the system. Now, consumer-directed health care is underinsurance by definition. If you have a high deductible health plan, $2,000, $5,000 deductible, sometimes called consumer-directed, it's underinsurance. That's what it is. And underinsurance will not protect you if you get sick, and it won't protect you economically. Most people who have high deductible health plans do not have health savings accounts. They don't have medical savings accounts. The medical savings account is something rich people do as an extra IRA. Low income and working families who get high deductible health plans do not get employer contributions into a savings account. That's the big blue part of the circle, is the people who got no health savings account with their high deductible plan. And the problem with these $2,000, $5,000, $10,000 deductibles is the average American does not have assets available to pay a high deductible. So the average American, if they get hit by a truck, doesn't have $5,000 to pay. And these are the median net financial assets of American households. And you know, just I'll draw your attention to the third one of uninsured people over 300% of poverty. So those are the people who might be mandated or whatever to get insurance. The average net financial assets is only $100, okay? So people don't have the money in the bank, and if people have these high deductible plans, it means they're going to go into debt. And mostly they'll go into debt on their credit cards, the worst kind of debt to take on, but that's what happens. And this is just some data from the RAND health insurance experiment showing that when people have to take large amounts of money out of their pocket to go see the doctor, they don't go. And that's just common sense. But this was proved in a study that they don't go for serious symptoms, they don't go for minor symptoms, they don't go for immunizations, they don't go for preventive care. You reduce the use of all types of medical care when you give someone a high deductible plan. So if these high deductible plans are so wretched, you know, who's in favor of them? And I think the answer is kind of obvious. If you stand in Cambridge, Massachusetts, where I live, and you look out at the river view, the skyline across the river at Boston, and those are our two tallest buildings. On your left is the John Hancock Tower, and on your right is the Prudential Tower. Okay, and those tall buildings represent the immense financial and political power of the private health insurance industry. Okay, immensely powerful, and that's why we can't get the debate about real change. But without that debate about real change, literally millions of Americans are going to find themselves facing this economic maelstrom without a health care lifeboat. Okay. The good news, however, is the majority of the American people, in fact, endorse the idea of national health insurance. And this is the most recent poll I could find. It's a couple years old. But would you prefer the current health insurance system or a universal coverage program like Medicare that is government-run and financed by taxpayers? And it turns out that a clear majority of the American people endorse that idea, support that idea. Similarly, when we polled a random sample of physicians in our own state, we got a majority of physicians, shown in pink, endorsing the idea of single-payer health care. So in some ways, we have very good news here that, in fact, the American people are behind this idea. What's really involved is educating, mobilizing, using some of the tremendous energy that's being generated in this election season to get the real health care that Americans need and actually provide us all with the lifeboat that we're going to need if we're going to survive these economic maelstrom. So I gave a lot of data very fast. I do want to call your attention to this website because I will put most of this material up on the website, and for all those slides I kind of ran through at a very rapid pace, you will be able to get a hold of them and look at them more closely. But great, so now we've got plenty of time for questions. So would you like me to come over there? Yes, okay.
Well, thank you so much. We all learn. When you're talking about something I think we all feel is looming, the economic maelstrom, and obviously all calculations are off in terms of where we're heading because we don't really know. But assuming that President Obama is elected, and you've pretty much diced and sliced his plan, when do you think the debate that we aren't having, that we should be having, that we're trying to have here and now, will start getting some traction?
Well, I actually expect a lot of traction after the election because, assuming an Obama victory, hoping for an Obama victory, because people are really fired up and they think change is possible. And if people really believe change is possible, then it probably is. And I just remember what happened with Kennedy. I was a child, but certainly I know the history that John Kennedy was a very centrist kind of guy. He wasn't particularly radical in what he had to say. But his election raised everybody's expectations, raised everybody's hopes. And once people got their expectations and hopes up, the entire 60s unfolded, and all sorts of political change became possible in ways that people, Kennedy certainly never envisaged. So I think, Obama is at the head of a whole movement of people that are very fired up. The other thing I would say about Obama is he's never been ideologically opposed to single payer. In fact, he said at several rallies, single payer would probably be the best if we just had the political will to do that, but he doesn't think it's, quote, politically possible. So we're not facing someone who's ideologically opposed the way a John McCain would be or a Bush would be or has been.
And do you think there's any way that you can get traction in the business community? Because three of the most venerable companies in American history are about to go under: Chrysler, Ford, and General Motors, and they're getting government bailouts. Andy Card, he was sent to Washington. He was GM's guy in Washington. Instead of lobbying for single-payer health care, he was lobbying against seat belts and every other thing. But at the end of the day, they're moving their factories to Canada for the very reason that they're going broke because of the accumulated healthcare costs and pension costs. It's as clear as day. And you'd think that big corporations would see the logic of not having to carry all this stuff on their books.
Well, you're absolutely right. Everybody knows about the contraction of the automotive industry in the U.S. There's actually been a big expansion of the automotive industry in Canada. There's been $5 billion in new automotive investment in the last few years. And the wages in Canada are not lower than in the United States. It's really the benefit costs that are so much lower. So the United Auto Workers are aware of this, and certainly the automotive corporations are aware of this. We've not had a lot of contact with the automotive corporations recently. We did when Iacocca was around. He sort of flirted with supporting single payer. But we do have a lot of contact with the union, and what they're saying is that they're just afraid, they've been afraid under the Bush administration that if they endorse single payer, then all the sort of government bailout and money they've depended on, frankly, would stop flowing. So it's a business decision. They can't really endorse it. But the automotive industry has much more problems with health insurance even than other manufacturing industries for historical reasons. They have a lot of retirees, and it's been a bigger issue for them. I think there's a lot of people in the business community who would not oppose national health insurance at this point. We haven't seen a lot of business leaders come forward to lead the charge.
And you talked about the Medicare HMOs. I mean, Is that just a part of the kind of Republican ideology, if that's not too kind a description, of transferring public funds into private hands? Because it's the metaphor or would be that the government takes money away from the post office and gives it to UPS and FedEx. I mean, that's what they're doing,
Yeah,
essentially.
Yeah, that's absolutely what they're doing. It's our tax dollars, and I mean, I don't mind paying taxes for Medicare for older people, and sort of part of the social contract, and other people pay for me when I get older, I guess. But it's our tax money being handed to Aetna and United Healthcare, and they give them 13% extra just for being Aetna and United Healthcare, above what they would pay if they stayed in traditional Medicare. So it is just this cozy relationship between government and the insurance industry. And the insurance industry has been pushing for it very hard because there has actually been a shrinkage, a contraction of the employer-provided health insurance. As the GMs and the Chryslers of the world shrink down and the manufacturing industries shrink down, there's fewer and fewer jobs that offer health insurance to their employees. And that's been a slow process, but actually a steady one, where every year it shrinks by about 1% or 2%. So the insurance industry is out there saying, we need new markets, we need new places to go to make money. Hey, let's go into Medicare. Let's get the taxpayers to give us this big subsidy, and we'll take over Medicare and we'll make some money that way.
So what is this advertising campaign that I see that the AMA are doing, where they talk about the 46 or 47 million unemployed, then they say, well, we'll let you know what we're thinking about it if you write into their website. So what's happening there?
Well, the good thing, the good news is the AMA is at least talking about it. That's the only good news there. If you look at the plan, it's very similar to the McCain plan, where there's like a tax credit, and they pay for the tax credit by basically taking the tax subsidy away from employer-sponsored coverage. No serious health policy analyst thinks you're going to get universal coverage with a system of tax credits. And there's lots of people who'd be a whole lot worse off. So it's quite a bad plan the AMA is proposing, and very similar to the Republican plan. But most people are not looking at their plan. They're just seeing the advertising, and I'm very glad the AMA is talking about the issue.
Well, it's I mean, we are going broke, isn't that? That's inexorable.
You mean the healthcare system?
Yeah. That none of it's supportable, is it?
Well, if we were getting good value for money, that would be one thing. But we're getting very poor value for money. I mean, I showed you some of the numbers. Countries that spend half as much as we do have a longer life expectancy, a lower infant mortality, better scientific output. So, yes, the absolute amount is too much, but also we're getting very poor value for money, and we're completely insecure with it. So even folks like me who get my insurance through Harvard, I get like the Cadillac plan, I guess, but it's still very insecure because the minute I stop working for Harvard, the insurance is gone, unless you've been there long enough to be eligible for the retiree stuff. So the insurance is gone. So if I got sick and couldn't work, like, the insurance would be gone. And frankly, even with the Cadillac plan, my daughter's had a series of athletic injuries. Over 3 years, we had about $5,000 in co-payments 3 years in a row. And yeah, I could sustain it, but the average American family might face bankruptcy with $15,000 in co-payments over 3 years. So even people with the best insurance are not very secure, particularly in this kind of economic maelstrom where who knows whether what your job's going to be like. So that's really the issue, I think.
So just how politically, since you are the co-head of this organization that's trying to bring about this kind of healthcare reform, and you're obviously trying to get your message out, and I imagine the specter you're facing is the S word, socialism. I mean, it's now Governor Palin is using that word as we speak. But yet you've shown two slides here, one sourced by ABC News and the other one by a group in Massachusetts, that indicate that the public actually, majority of the public, are in favor of it. So what's the problem here? Why is it that the insurance companies can invent Harry and Louise, or whoever those characters were, that killed the Clintons' plan? They seem to be able to just kill this stuff off dead on arrival, bring up the specter of socialism, and yet the indications are that the public out there is actually receptive. With the right information, they might well be motivated and mobilized.
Well, I think there's an absence of political leadership. That the Clinton plan was very confusing. It was 250 pages. It was actually a mandate proposal with a very heavy role for HMOs, though it incorporated a lot of funding to try to get to a universal, but it was a mandate model and done primarily through private health insurance. Good political leadership would be pointing at single payer and saying, no, we don't need to spend more. We can take the money we're now spending, cover everyone, improve everyone's coverage. That's a message that would resonate and mobilize people, where the 250 pages of incomprehensible verbiage was not a very mobilizing message. So we need real political leadership here. I think, to be honest, I think what's going to happen is that we will hit a point where elections will be won and lost on the single-payer issue. And, I'll tell a little story in that regard. I was actually in Washington in the early 90s when the health care debate really opened up, completely, and everyone's talking single payer, and the Clinton proposal is what we ended up with. But why did things open up then? And it was somewhat serendipitous. There was a very popular Republican Senator Hines who was in a plane crash, and they had to have a special election to fill his seat. And the very popular Republican governor wanted the seat, Thornburg, and he was running against an unknown Democratic state treasurer, virtually unknown Democratic state treasurer named Harris Wofford. And the Thornburg people must have gotten a very bad focus group or something, because they made this very silly mistake. In the last 3 weeks of the campaign, they blanketed the state of Pennsylvania with ads saying that the Democrat, Wofford, supported single payer. It wasn't even quite true, okay. But that's what their ads said, Harris Wofford, socialist, single payer, you don't want it. And then Wofford won, okay. And, it was like a thunderbolt. I was in Washington. It was like a thunderbolt came out of the sky, and it changed everyone's mind that, health care was really important. This idea really had legs, that, elections could be won and lost on it. So that's what has to happen. And to get to that point, we need forums like this and people like this to be out there talking about the issue, learning about the issue, and holding the politicians' feet to the fire and saying, if you want to be our representative, our senator, you're going to have to endorse single payer.
So much of our debates are framed by semantics, and there's a number of studies. George Lakoff and Drew Weston and others have written about how much better at framing things the Karl Roves of this world are than people like yourself who are on the other side. So how would you, when you say single payer, I don't know that even everybody knows what that means. How do you, in a succinct way, describe the simple logic of single payer, in the sense that you get rid of the middleman and you pool the money, and it just has an inherent logic in it. So what's the best way you think you can describe it simply?
Well, single payer is not a term that I coined. When we formed our organization, we called it a national health program, which is not particularly informative either. But it does have a certain implication of a national government taking control of things and being health-oriented. The reason the single payer thing has been so persistent is it describes the core financing mechanism, which I do believe is the core of understanding health policy. I actually teach health policy at Harvard, and I always tell my fellows, my research fellows, that health funding, health financing is the alpha and omega of health policy. The whole question of health policy really hinges on the funding issue, and single payer does capture that. That is, all the money goes into one pot, and that covers all citizens equally for all medically necessary care. Single payer. And you get the administrative savings from single payer. There are no administrative savings possible without single payer. You can't have 1,500 insurance companies with different rules and co-pays and deductibles. You can't have 1,500 of companies and get administrative savings like you get from a single public system. It just can't happen. So that's why the word has stuck, even though single, is that good? I don't know. Payer, is that good? No. George Lakoff would criticize it, and in fact, we invited him to our meeting, and he came and, told us we had used all the wrong words. But it is actually the essential mechanism, and I mean, he had some wonderful things to say. That's why we really appreciated him flying over to talk to us about it. But that's, I'm not a rhetoric person, to be honest. I'm a policy researcher and a doc, and mostly I spend my time with those kind of audiences trying to explain this. But certainly if you have better words.
Let's bring the audience in, because I'm sure you've all got questions. Everybody, I think, feels deeply about this, since everybody's witnessed some personal tragedy and seen their savings wiped out, or their parents' savings, etc. The gentleman on your left there.
Yes, thank you. The other day I was at the doctor, and he told me the government wants to make us poor. How do you respond to that? Is a doctor trying to brainwash me, or what is the story there?
There's a lot of political variety in the medical community. We have 15,000 physician members. Polls are showing, majority support in the physician community for national health insurance, but it was certainly not universal, and I'm sure there's doctors out there who are completely opposed to anything that would be spread the wealth around, if you will, redistributive. Personally, insurance is about spreading money around. It's about healthy people, those of us who've been lucky enough to be healthy, work and we pay into insurance, so people who are unlucky and get sick, can have care. And it's a social contract. We know if we get sick, it's the money's spread around. So I'm all for spreading money around in healthcare. I think that's the basic idea behind insurance. It's something government ought to help us do. But yeah.
Yes, the gentleman next to you there.
Oh, okay.
Oh, sorry, the lady.
My question is, it's just trying to see getting politicians on board with basically saying, let's shut down an industry, because that's basically what you're saying is get rid of insurance companies. And that's the same as saying, let's take an entire industry and make it go away. I can't see any politician being on board with that.
Well, every nation that's enacted national health insurance had to eliminate or make redundant the health insurance industry. It's not illegal to do that, okay? It's certainly constitutional to do it. So you're just saying, is it politically possible given the power of the insurance industry? In this country, yeah, and they are very powerful. But there's 18,000 people who die every year in this country because of the private health insurance industry. And a little bit the question you're posing is, do we have a democracy? Can we take the view of the majority, that is, the view of the majority is we should go to some form of national health insurance? Can we go from that view to a political process that makes it a reality? And I know it's corny, but I actually still believe in democracy, and I think that that's what we're here for, is to actually make democracy work. It's not a spectator sport, obviously. I think people are learning that. So yes, I think it is possible to, in the power of the insurance industry, to win this, but it's going to take work. Yeah.
Now, are these two things mutually exclusive, though? In other words, could you have a a national health system, and then you still have private insurance? Because to some extent in England they have national health, but if you're wealthy enough or if you feel strongly enough that you don't like the government doctors, you're free to go to Harley Street to some specialist. Or
Well, that is true in England. They do allow a private sector to compete with the public sector. It's been relatively small. Like if you're really sick, you go to the public sector, the NHS hospitals. If you just need your gallbladder out or something, people go privately, and they have nicer rooms and food and stuff. I actually think allowing the private sector to compete with the public sector in Great Britain is responsible for a lot of the problems in the British National Health Service. Of the European nations, it has one of the least successful health insurance systems, and I think largely because they've allowed the existence of the private sector. What happens if you have a private sector is rich people know they can buy their way out. That if the lines get to be too long for a gallbladder surgery, or the level of amenities in the hospital is not high enough, the food's lousy, and there's no private rooms, they always know they can just spend their money and buy their way out. So rich people who have a lot of political power don't put any of their political power into maintaining the quality of the public system. And of course, we kind of see that with Medicare in this country. By the way, it is illegal, or it has traditionally been illegal, to sell private insurance that competes with Medicare. Okay, we see that with Medicare. Medicare's been a pretty decent program, as opposed to Medicaid, which is for poor people, which is a lousy program, provides lousy care and not very good access. And the reason Medicare's been good is that rich people have been forced to rely upon it. So that's why I don't want a private sector. They haven't really had one in Canada. They've had everyone in a single payer. They haven't traditionally had one in Australia. They have a single payer. And the health systems are better maintained because rich people have to rely on them too, and they use their political power to maintain the funding. And just to stretch an analogy, maybe painfully stretch an analogy, the lifeboat analogy. If rich people have to be in the same lifeboat with poor people, the lifeboat's going to be kept in good repair. Okay.
yes,
Please wait on the
yes,
microphone.
this gentleman here. There you go. No, the microphone. Yeah.
Oh, I'm sorry.
There you
Okay,
go.
thank you. First of all, may I say, Steffi, it's a pleasure to meet you or see you in person. You are the Joan of Arc of healthcare reform in every sense of the word. I just got to say, it's a thrill to be here. Doris Nelson is sitting right ahead of me here, and she's the founder of, one of the co-founders of Healthcare for All California, which was a year ahead of PNHP. I didn't know that. I wasn't sure of the time. But in any case, I'd like to jump back to, thank you for coming out, and thanks to Hammer for doing this. I'd like to jump back to the communications thing that you brought up, Ian, is that we in California just 2 years ago started the California OneCare campaign. Actually, we call it onecarenow.org. And we use the phrase OneCare as both kind of signifying single payer, but also one risk pool. And coming at it from a risk pool standpoint, I think some is one way. It's funny, I'm an advertising guy for 40 years, advertising copywriter, and I've been struggling with this, trying to come up with the right kind of language, the way of putting this across. It's a tough one, and so we all need to be working harder on that as well. But had you seen, actually you are in our video, I don't know if you know that. Do you know you are in the OneCare Now video? And comments on the California OneCare theme?
Well, in many states, there's actually a state-based effort, and not all 50 states. Some of the folks within our group work on these state-based efforts. I actually mostly work on national level work. This is part of how we move forward, as people who can work feel they can make progress at a state level, have been pushing for it at the state level. I and a lot of other people trying to work on a national level. We do see, our group doesn't advocate a 50-state solution. That is, we don't see there being 50 different health plans developing, but we are thinking that there might be a springboard model where single payer is enacted in one state and can become a springboard to a national program. So.
Where's the microphone there? Oh, there. This gentleman here. Steph, maybe you should turn the mic this way.
Okay, yeah, it's a little twisted, I guess.
You mentioned a lack of leadership, but there's already legislation in front of Congress for a national health insurance program, single-payer, government-funded. I think it's called the National Health Insurance Program, but the official name is House Resolution 676.
Yes.
That Dennis Kucinich often alluded to in his campaign. I'm just curious, who in the audience has heard of that bill?
Yeah. Yeah.
So it's probably less than 10% of the audience. I guess my question is, do you support that bill? And if you do, what do we do to get it passed?
Yeah.
I mean, now would probably be the best time. Obama would probably sign it, and we're likely to get, a Democratic-controlled Congress.
Yep. Well, H.R. 676 is a very good bill, and it has been, the lead sponsors are John Conyers, who is sort of the dean of the Congressional Black Caucus, and Dennis Kucinich, who obviously ran for president. It has about 80 co-sponsors, which is great, and it's one of the ways that a lot of the local groups work is by getting co-sponsors. It's got a lot of support within the labor movement. There's been literally hundreds of labor unions and more than half of the state feds, if you know what that is. It's the AFL-CIO Council for the state. More than half of them have endorsed it. So it's been a great vehicle for doing work. But we're obviously going to need a much bigger push. 80 sponsors is a long way from a majority, and but it has been a great way for people to work. Oh, no, we're not trying to get a different bill. Again, there's a lot of, this is a big organization and a lot of people work in different ways. And some of our members and chapters work almost exclusively on rounding up sponsors for that bill. And others support the bill but are actually working on more general spreading the word and publicity around the idea. Yeah.
Audience here, I mean, I think like a too low percentage even knows about it. I mean, that's not any one person's fault, but I think, just looking at the polls you said before, 56% of the populace supports national health insurance. Now's the time. I think
well,
the legislation's there, it's written, and the future president would sign it.
Yeah. But I think a very good way to start to work around the issue, if people are looking for ways to do it, is to get a resolution. Go to any organization you're part of, your Department of Medicine, I mean, that's what, your medical school class, your synagogue, your church, your labor union, and you take a resolution saying, well, let's support H.R. 676, and let me explain to you or give some materials to you as a group about what single payer actually is. And certainly our PNHP office and some of the local people can give you sample resolutions, but it is one really good vehicle for talking about this, but it's obviously not the only vehicle. Yeah.
Gentleman here in front. That's okay, we've got.
I just want to make two comments, and then I have a question on data. One is, I'd like to answer the woman who was worried about the political will. I think there's a lot of political will. The California State Legislature twice by 60% margins in both houses passed single payer. The governor vetoed it, and in his September 06 veto, he said, in his own words, he wants to keep the private health insurance companies in the loop. And we know what that means. And on September 30th this year, he vetoed it again. There are 94 co-sponsors now of the Conyers bill. That's a quarter of the House of Reps who's willing to wipe out the insurance companies. That's pretty good for political will. And a couple of those guys are moving to the Senate. Tom Udall in New Mexico, who's one of the co-authors, is like 15 points ahead for the Senate seat in New Mexico. And I'm sure we'll have a Senate sponsor for that. But I have a question on the data. What I did was I took the total amount spent on healthcare in this country, $2.3 trillion. Now, is that figure off? Because I divided that by 300 million and I got over 7,600 per person, not 6,100 as it said in the slide. I think the medical expenses are grossly underestimated in most of the presentations that I've seen. What's wrong with my figures?
No, your figures are correct for this year. In order to compare across countries, I had to look at data from a couple of years ago because that's what's available. And the data source I use is something called the OECD, the Organization for Economic Cooperation and Development, and the most recent data available is what I showed you. But you are right for 2008 that it's over 7,000.
2007, I got the 2.3 trillion from CMS.
Uh-huh.
That's the government figure
Yeah.
for,
Uh-huh.
and
Okay.
I just divided by 300 million. I mean, was there anything wrong with that?
No, that's correct. You are correct. And
That's
it,
from 2007.
yeah.
Do you have a professional affiliation? There's a mic there if you need it.
I've been working on this stuff for a long time. You probably can tell. I worked on Prop 186, which was a single-payer healthcare thing, on the ballot in 1994 here, and Healthcare for All was formed in the spring of '95 after the defeat of that bill. Our polling showed that was going to pass 2-1. We had like a 67% yes, and it was defeated 76-24. The insurance companies in the interim put on an advertising campaign that only had one point, which was a 100% lie. If this passes, you lose your choice of doctor. And the bill specifically said it opens your choice to any provider in the state, including acupuncture, chiropractors, it was a total, absolute lie.
So what did you learn from that defeat?
That we need, in the words, we used medical terminology when Healthcare for All was founded. We need to inoculate the population in advance against a tidal wave of horseshit that's going to come down from the insurance companies. We need these inoculations, and I think we've been doing very well. We got it past the legislature twice in the last few years. I'm also working on the labor task force for universal health care, which is now spreading nationwide. There was a nationwide conference call just recently, and it's 36 state AFL-CIO federations have endorsed, and a huge number of locals. Our little local health unions for healthcare has 40 paying members. We have enough money to have a staff person and an intern from the UCLA Labor Center working for us 20 hours a week. So we're doing very well inoculating the population.
Very good.
Any questions? More questions? Up there, yes. Oh, no. Is it the same guy?
Hi. I remember seeing a PBS program where they went through different countries, including the German system where they have Krankenfunds. Maybe some of those buildings with the insurance companies that go empty could become Krankenfunds.
Well, this is what he's talking about is that you have these you might have nonprofit insurers, and you could take some of the investor-owned or profit-seeking insurers and use their capacity, I guess, to administer national health insurance. I guess that's what you're saying. And certainly when Canada went to national health insurance, they did hire some of their staff from the private insurance industry to come into the government and run the government-sponsored insurance. The issue there is that the insurance industry is actually quite large. It employs almost 1 million. Health insurance industry employs about 1 million people. So we don't actually need 1 million people to administer national health insurance. We maybe need, 25 or 30,000. So what our group has done, and in fact, we've worked a lot with labor unions, and we've talked a lot about a conversion program, because it's certainly not the fault of the insurance workers, the healthcare system. It's not their fault, So they shouldn't be punished if we go to national health insurance, but we should have a conversion program the way that we used to talk about in the anti-nuclear movement for nuclear workers, where you set aside some of the initial savings, you set aside for job retraining, income support, allowing people to go back to school, and make sure that the income of the displaced insurance workers is supported while they retrain for other things. And we've actually, the labor people we work with kind of costed it out, and it's, $20-40 billion to run one of these programs, which, sounds like a lot of money, but as this gentleman is pointing out, it's peanuts in healthcare. Healthcare is a $2.3 trillion industry. A third of it now going for administrative costs. We could cut that in half with single payer, and savings of about $400 billion a year. If we have to divert $40 billion for some of this retraining, it would be money very well spent.
And I understand that the Australian system, single payer system, the number of employees that administer it is incredibly small.
Yes, well, the public part of the Australian system, and they have, as in many of these countries, the private insurers have been the barbarians at the gate, if you will, who've been, getting little pieces of it privatized. But certainly the public part has been extremely efficient. I'm most familiar with the data from Canada, and for all of the national health insurance in Canada, there's estimated to be only about 6,000 people who work on administering insurance, which is fewer people who work than the number that work for Massachusetts Blue Cross, which covers 1.5 million people. So, unfortunately, there's not going to be jobs for all of these people. Fortunately or unfortunately, there's not going to be jobs for all of these paper pushers. But the workers themselves, we would really try to protect in that setting.
Any more questions? Yeah. This gentleman here in the front, in the middle. Yeah.
Thank you. It's often said that the rest of the developed world has better health insurance than we do, but actually it's not single payer in many cases. It's not socialized medicine. I wish it were. But in Switzerland, for example, I understand there's a lot of private care provided, but the key feature in all of those more successful plans seems to be that they're not for profit. One other thing I wanted to say, since I have the opportunity now, is not a question so much as a point of information. I recall Obama early in the primary campaign answering a question from his audience about single payer. And his position at that time, I've never heard it repeated since, but it was that we couldn't live with the loss of all the employment that would represent it in insurance companies.
Well, I do want to, let me just answer the thing with Switzerland. Switzerland does have what they call private insurance companies. They've traditionally been nonprofit, but they're very, very highly regulated, and they're nothing like our private health insurance industry. For instance, they have to take all comers, like anyone who wants to sign up can sign up with private insurance, so you can have AIDS or cancer or multiple sclerosis, and they still have to take you. And I mean, that's inconceivable in this country with our private insurers. People with foot pain tell me they can't get health insurance. They saw a podiatrist twice and they can't get health insurance. So they had surgery 25 years ago and they can't get health insurance. So if they're out as an individual. So it is a very different animal, what they're calling private insurance in Switzerland. I do want to say as well, though, I mean, there's going to be a loss of insurance jobs, but if we're transferring that money, that administrative cost savings, over to health care, there will actually be an increase in health care jobs. And dollar for dollar, they'll offset each other. So for every, if you transfer...
Obama's thinking is quite muddled on that.
Yeah. It is, but if you transfer, $500 billion from the insurance industry over to healthcare to provide healthcare, then, there's the jobs here go down and they go up by the same amount. So certainly in the short run, where we're saying we're not increasing spending, we're not decreasing it, we're just moving the administrative costs over, you would have this increase in healthcare spending. So certainly, it's real easy to think about it at a hospital level because there's actually a lot of paperwork and record keeping in a hospital that you need to do just for patient care. So if we could take some of those billing staff who are now filling out bills and bring them up to the wards to help the nurses with their paperwork so the nurses could spend more time with the patients, that's kind of easy to think about. It is a little harder with the insurance workers, being as there's so many of them.
Over here.
It seems to me like to get a what was the word to get a single pay program going or a national health care program going, it would require the I guess the rich, as you say, to be willing to jump into that lifeboat, I guess, with the the rest of the society. And I guess how realistic is it that they won't be apprehensive to do so when they really, I guess, have the option? They really don't necessarily stand to gain much one way or the other. I mean, you said there were 56%, I guess, of the population that were all for it, but how much of that percentage constitutes the rich? And I mean, for me, right off the bat, it seems like a lot of the people who are rich would probably want to just keep things the way they are, especially those who are rich because of insurance companies and insurance industry.
Yeah, well, I mean, this is a sophisticated audience, so I want to give you a fairly sophisticated answer to that. On one hand, quite affluent people are unhappy with health care. So if you go and talk to your, maybe not your billionaire friends if you have any, or your multimillionaire friends, but affluent people, hundreds of thousands of dollars in income, and ask them if they like their health insurance and what they think of it. A lot of people are unhappy about it. And a lot of them have had the kind of experience I have, where you think you have good insurance until your kid gets sick, and then you find thousands of dollars come out of your pocket every year for care. Or like affluent friend I was with last night who was trying to take some time off of paid employment for a while, and their biggest problem is she can't get health insurance, So there are a lot of people unhappy, including very affluent people. But let's get real here a minute with this. This is a sophisticated part. I mean, social spending, anytime you pay for something socially, like health care or schools or defense, the rich people are paying more and lower income people are paying less. And rich people can become a permanent lobby against social spending. I mean, in some ways, that's what the Republican Party is, in my view. It's a permanent lobby against social spending. Now, it's not just here with the Republican Party. They have them all over the world. Rich people understand that any spending that's social is redistributive. It's almost always cheaper for a rich person to say, no, I'll pay less taxes and then I'll buy privately. So that's always what you're up against, is that there are the Republican parties of the world, the Conservative Party in Canada, saying, no, don't do anything socially. Let's pay privately because social spending tends to be redistributive. But I think in health care, we've still got a good shot at it because the health care system is functioning so badly for the middle class at this point. And quite a ways up the middle class, people are very unhappy. And it's actually a lot of doctors are unhappy. I mean, who would have thought you could get 15,000 doctors to endorse an idea like this? It's just our daily, and it's not an income issue, the income's actually fine for doctors. It's our daily life is being made miserable by the insurance companies, And the patients come in, there's a lot of stuff we can do. We can prolong their life, we can make them healthier, we can make them happier, but we can't do it if the insurance industry won't let us do it. And we can't do it if there's no financing to pay for the things our patients need. So, I really think that there's a lot of, that it is redistributive. Let's be sophisticated about that. We're talking about sharing wealth around, but this is a place where I think a lot of middle, upper middle, and even affluent, quite affluent people would think this was a good idea.
As an anecdote on that,
Yeah.
Christopher Reeve, before he died, he had one of those health plans where he got like a $2 million lifetime maximum, and he went over that before he died.
Yeah.
And so, I mean, that level of healthcare prices send even rich people bankrupt. So I think there's benefits for them as well. Support reform.
Yeah.
Yes.
Hi, yes. Oh, sorry. For my understanding, from my own experience, is that I feel I'm from Chile, and in my country we have a different system for health. But something that I notice here in the States is something that mentioned this gentleman here, that here is a business. the approach to healthcare is a business. It's not like a right for people. It's approach from pharmaceutical companies, doctors, health insurance. Everybody's on the boat. So what happened is you go to a doctor, for instance, and then all of a sudden a nurse is making $100 a day on her shift. You being charged $1,000 for her to take your blood pressure, you know? And I understand it's sort of economics thing because the hospital have to maintain themselves. But it's kind of like knowing that your shoes cost really $1 to make it in China, but you still pay $100 here, right? So I feel that there has to be a cap where you're not going to be charged $400 for an aspirin, where you can get it in a 99-cent store for a whole bottle.
Okay. Well, there certainly is a lot of what I would call profiteering that you're describing, where the prices are like ridiculously high. And I know there's a eye drop called Zalatan that's used for glaucoma, and there was sort of a scandal. It costs $100 a month if you have glaucoma to buy this stuff. Only it costs half a penny to actually manufacture it. So yeah, there's certainly a lot of profiteering going on. At the same time, certain things in healthcare are going to be expensive. Good diabetes care is going to be expensive. It's very it's very detail oriented. There's a lot of care involved. People sick with cancer, it's going to be expensive. Premature baby is going to be expensive. No one's talking about getting off cheap. We just want to get value for money. When we pay this money through our taxes, it's deducted from our paycheck as health insurance. We just want to make sure we actually get what we pay for, and we're certainly not doing that in this country.
This lady here in the front.
What's the pharmaceutical component of what you're talking about?
Okay, great question. Let me just start first with the political piece, because we've been talking about that a lot. Politically, the pharmaceutical industry has been very strongly opposed to national health insurance. And when I first started doing this years ago, I was really shocked that they were so strongly opposed. I remember Pfizer used to pay for a lot of my research that I do gets published, and then invariably some company pays to repeat the research to look for mistakes, okay? And Pfizer used to go around paying academics to repeat the research to look for mistakes. And as you can probably tell, I'm very detail-oriented. I don't come up with much. But anyway, I said, well, why is Pfizer going after me? Wouldn't this be like a big market for them, to sell more of Viagra or whatever it is they sell? And but it turns out that they knew something that I think the American people learned maybe 5 or 10 years ago, which is every country with national health insurance has negotiated for price discounts on pharmaceuticals. So Canadians get exactly the same drugs we have, only they pay 40% less. And actually our own U.S. Department of Defense, which is the largest purchaser of drugs in this country, also gets a 40% discount. So they knew that if there was a big single payer, they'd be forced to, give a discount, and they were opposed to it. And I think the pharmaceutical industry is a really big part of the problem at this point. They're a huge proportion of all profits in healthcare are going to the pharmaceutical industry. They take these new things that are developed in these small startups, and then the big companies buy them and just turn into these giant marketing and lobbying organizations to get the drugs approved and used by doctors. And they are really a big chunk of the problem. A lot of iatrogenesis, that is, a lot of harm is done by the overuse of pharmaceuticals. A lot of deaths in this country due to unnecessary use of new and dangerous medications.
Which they advertise on television and create a market for, don't they?
They create a market. One of my fellows actually did a project on free sample distribution, and samples are one of the marketing things that the pharmaceutical companies do, and often the free samples are the same drugs they're advertising on television. Those are the drugs they're making money off of and trying to promote. And in one year of our study in 2003, the three top drugs that were being promoted were Vioxx, Celebrex, and Lipitor. Vioxx and Celebrex are dangerous drugs. They increase the risk of cardiovascular disease. And frankly, Lipitor, which is a good drug, is an overpriced Me Too drug. It's, in most cases, not any better than the generic alternative that's available at the fraction of the price. She looked at pediatric samples, and some of the top drugs were quite dangerous drugs. Controlled substances were being given as samples to children. Drugs that have been withdrawn from the market because they're dangerous. So the drug companies really out there promoting the most profitable drugs, which by definition, because of patent laws, are the newest drugs, which by definition, in my book, are the least tested drugs, the least known drugs, and the drugs we're most likely to identify dangerous side effect in the future. The stuff that's been around for 20 years, we know what we're dealing with. The brand new stuff, we don't know. And there's sort of a joke in the medical profession, a bad joke, I guess, about, well, you don't use a new drug on your patients for 5 years, and you don't use a new drug on your family for 7 years, and you don't use a new drug on yourself for 10 years. It's a bad joke, but it does give you this idea, a new drug. Nobody knows the full side effect profile of a new drug. No one can know that, but that's exactly what the drug companies are always promoting.
This gentleman here in the middle.
Somebody back in the corner, too. We're looking
as a physician, I wanted you to comment a little bit on how would the typical doctor fare in a climate like this. I'm very much for the whole idea. I'm willing to put up with lots of stress and strain in a new system, but I didn't hear you address how the poor physician would be reimbursed.
Okay. Yeah, I actually often spend a lot of time on that. I do most of my speaking to actually medical audiences and something called Grand Rounds, which is a usually weekly conference that doctors do. So that, everybody's got to have that on their minds. And frankly, when I talk to medical students, it's on their minds too, if this is how you make a living. The Canadian doctors do pretty well. They really do. The average Canadian doctor earns about 4.6 times the average industrial wage. The average U.S. doctor, last time this comparison was done, was earning about 5.3 times the average industrial wage. Now, 5.3 sounds better than the doctors get in this country. 5 times a wage sounds better than 4.6. But the Canadian doctors are actually pretty happy. They don't have the kind of educational expenses that young doctors in this country have. They don't have their own medical debt is not very high because medical schools in Canada are free or close to free. And then the doctors my age, I've got 2 kids in college, and a Canadian doctor wouldn't have the kind of college tuition expenses that I have. So as far as I can tell, my Canadian colleagues have the same lifestyle, standard of living, whatever that we earn in this country. So I can't say to a doctor, you're going to be better off financially under national health insurance. That's not true. Probably won't be any worse off, but you're not necessarily going to be better off. I do think the quality of our working lives will be better because we're going to be able to focus on what the patients need and not always be having to think about money, and billing and paperwork.
The lady up the top there.
Yeah, somebody up in the corner who's not getting seen.
Oh, you're going around the back way. Okay.
Thank you. When you travel, are you hearing anyone talk about prevention? And is this, because this is something that I'm very involved in, and I never hear, I heard Barack Obama say it, and I almost jumped out the window. I couldn't believe someone talked about prevention, and all we talk about is Western medicine and the whole, and being a part of the system, but what about alternatives?
Well, I actually am a primary care doctor. That's my day job. So a lot of what I do is prevention. I'm a big believer in prevention. That's how I spend my day, though not necessarily what you're talking about. I do a lot of working with people around lifestyle issues. life choices, which often they don't have a lot of choices, but making healthier choices. I do a lot of what is now called secondary prevention. That is, people who have diabetes or high blood pressure, we can still prevent them from getting disability or complications of that. And that's called secondary prevention. So anyway, I'm very focused on prevention personally. Policy world knows that the geriatricians are much more important for population health than the cancer specialists, actually. So we have a big imbalance. The pay's like this, and we just can't get enough people to go into that field until we make the pay more equal. And as much as I'm sure the geriatricians and primary care doctors like me would love to get our pay raised, from a policy point of view, you don't need to raise the pay so much as level it, move them together, and then you'll get more primary care doctors to meet the needs. But primary care, we actually know this. This is not opinion. I am a primary care doctor, so I guess I have a conflict of interest here. But the scientific literature is very clear that the quality of care is actually higher, as well as cheaper. The care is cheaper if you have a primary care-based system, so that you have good, strong, well-trained primary care providers who are the first contact and coordinate the care and know the patients. So.
Okay. Anybody with a question? Yes.
The CEO of Pfizer was on a business channel the other day.
Why don't you take the mic?
Yeah, okay. Save your throat there.
I say the CEO of Pfizer was on a business channel the other day and was bragging that they're sitting on $70-some-odd billion of cash. They don't know what to do with it.
Well, I know
they
what
could
to
always
do
donate
with
it to
yeah.
Wall Street. They could donate it to Wall Street.
Yeah. Yeah, I mean, obviously drugs are tremendously expensive, overpriced, and a lot of people, don't get good secondary prevention, let's say, because they just can't afford the drugs. And it's one of the leading causes of non-compliance. Like, if I tell a patient take blood pressure medication and they don't take it, my first guess has got to be they couldn't afford it, because until we get good drug coverage and make sure people can afford it, we're just not going to get that good care to help prevent strokes and kidney failure like you can if you treat high blood pressure. So,
be the last up here.
I'm a senior, and I don't read much about medical care, etc. But is there a deadline now? I'm under Medicare and Blue Cross. Is there a deadline now for Medicare to end because there's no more money?
No.
Excuse
well,
me.
okay, yeah, that's an excellent question. Yeah,
I have part two of my question.
Yeah.
Because the thing I read in the newspapers is that when the time comes, Congress will just extend Medicare. But suppose they run out of money, they'll raise more money for Medicare. So is eventually Medicare going to end now?
No. Thank you for asking that question. The way the Medicare program is funded is they established a Medicare trust fund, okay, so that money, most Medicare funding is actually through the 3% payroll tax. So everybody who works in this country is paying 3% of their total compensation into the Medicare trust fund. There's also some general tax revenues going in, but it's mostly this payroll tax. And the money was put in a trust fund, and for a long time the Medicare trust fund was overfunded, and so the federal government would sort of borrow from itself, like move the money out of that account into general accounts. Currently, the Medicare trust fund, and then every year the federal government is required to say how many years worth of Medicare spending there is left in the trust fund. So they come up with this number. There's 10 years of funding, there's 27 years of funding, there's 40 years of funding. And if you've paid any attention to it, the numbers are all over the map, Now, when people want to scare you, they'll say the Medicare is going to run out of money in 27 years. But the reality is the money's coming from a payroll tax, so if they run out of money, they could just raise the payroll tax 0.5% and solve it. So there's a lot of games that are played with the Medicare trust fund. What is true is a lot of Medicare funding is wasted, and I was pointing out that a bunch of it's now being wasted with these HMOs that are allowed to participate. The for-profit hospitals really try to fleece Medicare, and sadly, I think a lot of what doctors are ordering is very expensive and unnecessary. Medicare's paying for it, and for every 100 Medicare patients, there's more than 100 advanced images ordered in any given year. It's about 102 advanced images for every 100 patients. And the typical cost of an advanced image is about $2,000. And a percentage of them are completely unnecessary. I'd just take a wild guess, half, I mean, this is my clinical impression, that half of the advanced imaging is unnecessary. But, you know, I'd have colleagues, and particularly radiologists and cardiologists that do a bunch of this would disagree with me, but I'd guess about half. So there is a lot of money wasted out of the Medicare trust fund, and it ought to be spent more wisely, and seniors would be much healthier if it was spent more wisely.
Well, ladies and gentlemen, I'm sure you'll want to join me in thanking Dr. Steffie Woolhandler for a really interesting talk.